Hello everyone, welcome back to the series of lectures in endocrinology. Today we'll be discussing about a very important topic, which is your growth hormone and related disorders. So let's begin. So we have learnt about the physiology of growth hormone in our chapter on the physiology of anterior pituitary. So we know that the growth hormone is produced from the somatotropes of the anterior pituitary. The growth hormone basically acts via another factor which is called as the insulin-like growth factor. So let us understand in detail about this growth hormone, its actions and the actions of insulin-like growth factor. So the growth hormone is basically a 191 amino acid hormone. Okay, so this has 191 amino acids. And remember that the secretion is pulsatile in nature. Okay, the secretion is pulsatile in nature. So the growth hormone acts on it. What are its target organs? So let us understand the target organs of growth hormone. Growth hormone acts on the liver, and this is basically involved in the production of glucose. Okay, and it is also involved in the production of insulin-like growth factor. Okay, so what are the peripheral actions of insulin-like growth factor? We will be looking at. The growth hormone also acts on the adipose tissue and it is responsible for lipolysis. It is responsible for lipolysis and production of free fatty acids. So this is about the metabolic functions of growth hormone. Now this insulin-like growth factor along with the growth hormone, it acts on the growth plate. It acts on the growth plate and is mainly responsible for growth in the childhood. It is mainly responsible for growth in the childhood as well as growth during puberty. So this is about the various actions of growth hormone. Okay. Now insulin-like growth factor has 70 amino acids and this insulin-like growth factor is bound to insulin-like growth factor binding proteins, the IGF binding proteins. So what is it stimulated by? Growth hormone is stimulated by thyroid stimulating hormones, glucocorticoids and sex steroids. It is inhibited by malnutrition and chronic inflammation. So many a times if there are children who have some inflammatory disorders in the childhood or children who are having protein energy malnutrition, they usually have a stunted growth because growth hormone is inhibited by malnutrition and chronic inflammation. Okay. So this is about your basic physiology of growth hormone and the IGF axis. Now let us understand growth hormone deficiency. Let us understand growth hormone deficiency. So growth hormone deficiency is manifested in children as well as in adults. In children, the main problem will be that there will be a problem with the growth spurt. Okay. So how do you assess for this? How do you assess for growth? So you assess for growth using certain formulas. So predominantly you assess the height. So the expected height is given by the formula mid-parental height plus 6.5 centimeter in boys or mid-parental height minus 6.5 centimeter in girls. So this is the expected height. MPH is your mid-parental height. So this is the expected height of an individual. It depends upon the parental height as well, right? Apart from that, to assess what type of deficiency of growth hormone and what type of a short stature you are having. So whenever you have a deficiency of growth hormone, you'll have a problem with the height and it will result in a short stature. So what type of short stature you are having? To determine that, we also have to find out the bone age. Okay. So bone age is basically determined by an atlas, what we call as the Grulich and Piles atlas. So what is the use of this Grulich and Piles atlas? So in this atlas, you have the bones of different age groups. So to assess the bone age of the child, you take the X-rays of the various parts of the child, especially the hands, forearm and the limbs. You compare it with the Grulich and Piles atlas. So you take the X-ray of the child at different parts such as the arm, forearm, the feet, and you compare it with the Grulich Piles atlas and you see at what age it is matching, and that is how you obtain the bone age, right? Then the bone age and calendar age, like a 5-year-old child should have the bone age growth of a 5-year-old child. So the bone age and the calendar age will go hand in hand. Okay. So this is how you assess for the growth. So first thing is you find out the estimated growth, you find out the expected height of the individual, that is obtained by the mid-parental height plus or minus 6.5. There are certain other formulas as well, and you can plot it on the graph to see whether they have reached that height or not, and how many standard deviations in that graph they are. If there are 2 standard deviations below or 3 standard deviations below the expected curve. For example, if this is the expected curve and you plot the height here, then they are below the expected curve. Apart from that, you also have to find out the bone age. How do you calculate that? You find it using your Grulich and Piles atlas, and you compare it with the calendar age or the actual age of the child. Okay. Apart from that, we also have to take into account the growth velocity. The growth velocity, that is every year at what rate is the child growing. Okay, so this is how you do your assessment of growth. Fine. Then what are the conditions where this bone age is delayed? What are the conditions where the bone age is lesser than your calendar age? That means that the height is not age appropriate. The height is not age appropriate and the bones are not growing fast. So this can be seen in hypothyroidism. It can be seen in malnutrition and growth hormone deficiency. So in growth hormone deficiency, the bone age is less than the calendar age, or the bone age is delayed. Growth hormone deficiency, malnutrition, hypothyroidism. Where is it normal? The bone age is normal in familial short stature. In familial short stature. So where the height is less than 3 standard deviations of the expected. In familial short stature, what happens is that the family itself is short. So they have genes of short stature. So there is nothing to do with the bones. They have a genetic potential itself of short stature. Where is the bone age advanced? That means that they are growing faster than the expected age of the child. They are growing faster. They are growing faster than the expected age of the child. And this is seen in hyperthyroidism. Apart from that, certain other syndromes like Beckwith-Wiedemann syndrome and Soto's syndrome. Okay, so Beckwith-Wiedemann syndrome, Soto's syndrome, hyperthyroidism, all of these is associated with an advanced bone age. Fine. So this is how you assess your growth and what is the importance of bone age. So if bone age is delayed, it is most often due to hormone deficiencies, right? Then let us understand the difference between your familial short stature and constitutional delay in stature. So let us understand the differences between your familial short stature and constitutional delay in your stature. So the final height in the familial short stature is less than 3 standard deviations of the expected height. It is less than 3 standard deviations of the expected height, right? In constitutional delay, what happens is that in constitutional delay, there is a delay in the growth, but finally they reach the expected height. So they reach the expected height. So when you see a short child, if the child presents to you because of lack of growth, you have to differentiate whether this is familial or constitutional, or is it syndromic, or is it any hormone deficiencies, right? So in familial short stature, they have a family history. The genetic potential itself is only so much. So they ultimately will be short only. But in constitutional delay, it is because there is no underlying cause, but they have a delay in the growth, but finally they reach their expected height. They reach their expected height. So family history is positive in familial short stature. It is not there in constitutional delay. What about the puberty? The puberty is usually normal in familial short stature, but it is delayed in constitutional delay. So there is a delay not only in the height, there is a delay in the puberty as well. What about the height velocity? What about the height velocity? The height velocity is normal in both, right? The height velocity is normal in both. The bone age is equal to the chronological age. CA is chronological age or the calendar age, right? So the bone age is equal to the chronological age in your familial short stature. But here the bone age is less than the calendar age in your constitutional delay in stature. Okay. So this is about how you assess for growth and how growth hormone deficiency manifests in different forms, right? So this is about your growth hormone deficiency in children. Growth hormone deficiency in adults, it is different. We will be looking at that. So What are the other features of growth hormone deficiency? In your growth hormone deficiency, other features can include micropenis, increased fat, high-pitched voice, and recurrent episodes of hypoglycemia. So apart from all this, there is definitely your short stature. There is your short stature. So what are the etiologies? What are the etiologies? There can be genetic conditions where, for example, if there is deficiencies in your somatotropes genes, like your prop1, pit1, this we have learnt as your genetic or developmental abnormality of the pituitary. Apart from that, they can be also due to hypothalamic disorders. Hypothalamic disorders which can cause hypopituitarism, can also cause growth hormone deficiency. What all are the syndromes, hypothalamic syndromes we had learnt? For example, Bardet-Biedl syndrome. For example, your Bardet-Biedl syndrome and your Prader-Willi syndrome. Okay, so these are some of the genetic causes. Then we come to growth hormone insensitivity. Your growth hormone insensitivity is also called as Laren's dwarfism. So growth hormone insensitivity is also called as Laren's dwarfism. In this, what happens is that the growth hormone is not able to act on its receptor. So there is resistance to the action of growth hormone. So actually, if you check your growth hormone levels in the blood or IGF levels in the blood, they both will be increased. So this is due to a problem with the action of the growth hormone on the receptor, right? So this is your growth hormone insensitivity. Okay, so this is about the various types of growth hormone deficiencies and how do they manifest. Now let us understand the management of growth hormone deficiency. So how will you manage this patient once you have evaluated, you have ruled out familial and constitutional short stature? Then you go ahead and look for endocrine causes of your short stature. So in your endocrine causes of your short stature, you have to look for your TSH levels, you have to look for your gonadotrophin levels, and you have to look for your growth hormone levels. Okay. Now the problem with growth hormone is that because this is pulsatile in nature, often it does not give us a valuable diagnosis. So we actually look for IGF levels. Sometimes the IGF levels also may not reflect your actual growth hormone levels, or it may not directly indicate if there is a deficiency, and hence what we would do is some stimulation test. Okay. And apart from this, whenever you find an isolated growth hormone deficiency, always look for whether other hormone deficiencies are there. Other hormones from the anterior pituitary includes your TSH, your GnRH and your ACTH, because you can have combined hormone deficiencies. Okay. But when you are assessing for short stature, never forget to do any of these hormones, because deficiency of any of these hormones, including hypothyroidism and hypogonadotrophic hypogonadism, can result in short stature. Okay. So the treatment is with recombinant growth hormone injections, which are given subcut at a dose of 0.02 to 0.05 mg per kg. In growth hormone resistance syndromes, there is no use of giving growth hormone, so we mainly give insulin-like growth factor as the replacement. Okay. So this is about your manifestations and management of childhood growth hormone deficiency. So how is adult growth hormone deficiency different from childhood growth hormone deficiency? So when you are dealing with an adult, you know that the bone plate or the growth plate is fused, right? So the growth plate is fused. Right, so the growth plate is fused. If the growth plate is fused, that means that the adult has already reached their final height. So adult growth hormone deficiency will not have any problem with the stature. Adult growth hormone deficiency will not have any problem with the stature. Rather, they will have a lot of metabolic symptoms. So let us look at that. So what are the features of adult growth hormone deficiency? It is characterized by an impaired quality of life, decreased energy and drive, poor concentration, social isolation. Lot of other metabolic changes, especially body composition related. There is an increased body fat mass. So there is redistribution of fat and there is an increased body fat mass. Apart from that, there can be central fat deposition, increased waist-hip ratio, and the lean body mass is reduced. So the lean body mass is reduced and there is redistribution of fat, there is central obesity. Okay. There can be reduced exercise capacity, impaired cardiac function, reduced muscle mass. Lean mass reduces, muscle mass reduces. So on the whole, what does all this predispose to? So basically, adult growth hormone deficiency predisposes to a lot of cardiovascular risk factors. There is impairment in the cardiac structure, function, and decreased fibrinolytic activity, abnormal lipid profile, finally leading to atherosclerosis. Okay. So growth hormone deficiency in an adult can have a lot of metabolic side effects. Then, how do you diagnose this? Okay, how do you diagnose this? So, when will you suspect a growth hormone deficiency and how do you diagnose this? So, growth hormone deficiency in an adult, when do you suspect? You usually suspect it in a patient who has undergone probably a pituitary surgery in the past, maybe for a pituitary adenoma, or patient who has undergone cranial irradiation or radiotherapy in the past. Right? So, for everyone we do not check. So, in these kind of high risk patients, we will have to check for it. Okay? And sometimes patient may be presenting to you with the pituitary adenoma which is causing growth hormone deficiency. Then they can have features such as headache, features of raised intracranial tension, features of mass effect, there can be compression on the optic chiasm, they can have visual field defects and so on. So, in such patients, if you are suspecting a pituitary cause, then you will have to look for imaging of the pituitary mass to see any evidence of structural damage. So, you can do an MRI brain. Okay. In your abdomen examination, what will you find? You will find that there is excessive of omental adiposity. The adipose tissue deposit is much higher. Okay. Fine. So, what is the laboratory testing that you will do? So, what is the laboratory testing that you will do? Whom to test? We have already seen pituitary surgery, history of pituitary tumors, history of cranial irradiation or childhood history of pituitary adenoma. If they have undergone a childhood resection, they can present in adulthood with growth hormone deficiency. So, what is the role of growth hormone and IGF levels in the testing for growth hormone deficiency? We know that growth hormone is basically having a pulsatile pattern of release into the blood. So, because of its nature of pulsatility, it is very difficult to identify or interpret your growth hormone levels because they can vary throughout the day. So, you can screen with IGF and IGF BP3, which is your IGF binding protein levels. So, you can screen with IGF and IGF BP3 levels, age match IGF if it is low, you can consider. But the definitive or the most validated test, most validated test will be your insulin tolerance test. It is your insulin tolerance test. So, we had discussed in our chapter on approach to hypopituitarism, how do you diagnose for these deficiencies? So, for your growth hormone deficiency, you use the stimulants for growth hormone like your arginine or your dopamine or your insulin. So, the most validated test is your insulin tolerance test. So, what do you look for in this? You give the patient insulin and then you see if you can induce hypoglycemia, the glucose level drops to less than 40 and the growth hormone response should be normally more than 3. If that is suppressed, that means that there is a growth hormone deficiency. Okay, so this is the most validated test which is being used for the diagnosis of growth hormone deficiency. Okay. Apart from that, what all you will have to check? You will have to look for your lipid profile, you look for your sugars, you look for the traditional risk factors for atherosclerosis. Okay, fine. Okay. Now, how do you manage your adult growth hormone? How do you manage your adult growth hormone deficiency? So, you give growth hormone which is usually given at a dose of about 0.1, so 0.2 milligram per day. Okay, and what do you monitor with? You monitor with IGF levels. So, you initiate them on growth hormone replacement and you monitor the IGF levels after 1 month. Okay, so usually we wait for response for up to 1 month or 6 to 8 weeks. If there is no response beyond that, you stop your growth hormone replacement therapy. If there is a response, you continue it and you serially monitor your IGF levels. Okay. So, what are the side effects of growth hormone replacement therapy that you should be aware of? You should be aware of fluid retention and arthralgias. So, these are the two most important side effects of growth hormone replacement therapy. Now, very interestingly, growth hormone is given for adult growth hormone deficiency. In adults, there are two other important indications for growth hormone replacement apart from growth hormone deficiency. This includes a condition called AIDS-related cachexia. Right, so we know that in HIV or acquired immunodeficiency syndrome, in chronic AIDS, you can have a lot of loss of muscle mass. They become very cachexic, right? They become very cachexic, where they become very thin, they become undernourished, there is a lot of loss of muscle mass. So, in these patients, growth hormone replacement has been approved as an indication for treatment. Apart from that, it is also been accepted as an indication for treatment for short bowel syndrome. For short bowel syndrome. Okay. So, this is about your growth hormone. So, what all have we learnt till now? We have learnt about childhood growth hormone deficiencies. We have learnt about the various syndromes. How do you approach stature? And what is the difference between familial and constitutional short stature? What are your growth hormone deficiency syndromes and how do you manage them? Also, we have compared it with adult growth hormone deficiency. Okay. So, in the next session, we will be talking about your growth hormone excess. So, now let us move on to the group of disorders which are associated with growth hormone excess, which is your acromegaly. Okay. So, what is acromegaly? This is basically a syndrome of growth hormone excess. There is growth hormone excess. Now, what is the meaning of this acromegaly? So, this comprises of two terms, acro and megaly. Acro basically means the acral areas or your extremities and megaly basically means enlargement, right? So, the group of disorders where there is growth hormone excess can result in this symptoms which is called as acromegaly, which means there is excessive growth of your extremities. Okay. So, let us understand the etiology of acromegaly. So, this can be due to excessive amount of growth hormone or it can be due to excessive secretion of growth hormone releasing hormone. We have learned that growth hormone releasing hormone is secreted from the hypothalamus and this is responsible for stimulating the pituitary to produce growth hormone. So, any defect or any excessive secretion with the growth hormone releasing hormone or growth hormone in itself can cause acromegaly. So, let us look at the causes. So, the first and the most important and the most prevalent, most common cause is the presence of pituitary densely or sparsely granulated adenoma. So, the most common cause for acromegaly is your growth hormone secreting pituitary adenoma. Okay. Then it can be due to mixed GH cell or prolactin cell adenoma. So, this can be due to mixed GH cell or prolactin cell adenoma, which means that both growth hormone and prolactin are being secreted, which is seen in 60% of the cases. Apart from that, you have your mammosomatotrope adenoma in 10% of the cases and few other types of rare adenomas. Okay. Very, very rare causes of growth hormone secretion. If not from the pituitary, where else can the growth hormone be secreted from? So, this can be seen in extra pituitary causes where you have your pancreatic islet cell tumors or certain lymphomas where you have ectopic growth hormone secretion. Okay. In your pituitary causes, apart from that, very, very rare causes or apart from your adenomas include carcinomas, Men's syndromes are associated with adenoma itself, McCune-Albright syndrome. Okay. The rare causes of growth hormone secretion, if it is not secreted from the pituitary, it can be secreted from the ectopic production sites. For example, your pancreatic islet cell tumor. Now, let us look at the other rare causes. As you can see, it is having a prevalence of less than 1%. That is because of your GHRH excess, growth hormone releasing hormone excess. Central causes includes hypothalamic tumors, right? Because this GHRH is secreted from the hypothalamus. So, tumors which arise from the hypothalamus like your hematoma, ganglioneuroma, choriostoma and so on. There can be ectopic production of growth hormone releasing hormone as well. There can be ectopic production of growth hormone releasing hormone. This is basically a part of what we call as this umbrella term for paraneoplastic conditions, right? So most often if there is ectopic growth hormone or growth hormone releasing hormone production, then you have to think of cancers and paraneoplastic conditions. Which are those cancers? Which are those malignancies? Bronchial carcinoid, pancreatic islet cell tumor, small cell carcinoma of lung. Small cell carcinoma of lung is very, very infamous for a lot of paraneoplastic manifestations. So this is one of it. Then it can be due to medullary thyroid carcinoma and sometimes even a pheochromocytoma. Okay, so sometimes even a pheochromocytoma. So this is about the various etiologies for acromegaly. So whenever you look for etiologies for acromegaly, what are the most important points that you have to take away from here? The most common cause is your pituitary adenoma. The other less common causes includes ectopic growth hormone or GHRH secretion. Ectopic growth hormone can be from your pancreatic islet cell tumors. GHRH secretion can be central or peripheral. Central because of hypothalamic hamartomas, choriostomas. Ectopic GHRH is most often due to malignancies. If you cannot remember anything, if you cannot remember any of the other causes, try to remember your small cell carcinoma of lung. Pancreatic islet cell tumors, medullary carcinoma, bronchial carcinoid, all of these are other causes. Okay, so etiology is clear. Now let us understand how does acromegaly present and how do we diagnose this. So acromegaly, basically because the most common cause is a pituitary adenoma, often this is indolent in nature. So the adenoma will be usually slow growing, right? It will be slow growing. So most of the patients are not acutely symptomatic. They are not acutely symptomatic. So what are the symptoms with which they present? You can have frontal bossing. Right? As the name suggests, there is an increase in the hand and foot size because there is acromegaly, so increase in the hand and foot size. So how will they present to you? What will they complain of? Right? So if your foot size increases, what will you complain of? You will complain that the shoes or the chappal that you were wearing prior is not fitting you anymore. Then, if there is an increase in the hand size, what will not fit you anymore? Maybe the rings that they are wearing will not fit, right? So there might be an increase in the ring size, there might be an increase in the foot size. Okay, then there can be something called as prognathism, which basically means that there is excessive soft tissue deposition in your jaw. There can be mandibular growth as well, and the mandible is pushed forward. So there is jaw or mandibular enlargement. That is what we call as prognathism. Okay. Then there can be widened spaces between the two lower incisors. There can be hyperhidrosis or excessive sweating. Acanthosis skin tag, because growth hormone excess can also be associated with some metabolic side effects, right? So there is lipid abnormalities and you can have acanthosis and skin tags. Apart from that, you can have carpal tunnel syndrome. CTS is carpal tunnel syndrome. Okay, so what is this carpal tunnel syndrome? So this is your palm and you have the median nerve which comes here and passes through this carpal tunnel. So what happens in growth hormone excess is that there is lot of accumulation of soft tissue, lot of accumulation of fluid and water. Okay, and there can be lot of accumulation of other glycosaminoglycans as well, which all of it can go and accumulate under your carpal tunnel, and as the hand or your extremities enlarges, the median nerve can get trapped, and that is what we call as carpal tunnel syndrome. Then you can have proximal muscle weakness, and it's not only your acromegaly, you can have visceromegaly. So if you examine a patient of acromegaly, you can have hepatosplenomegaly. Apart from that, you can have left ventricular hypertrophy. Hypertension. Because of excess amount of fat and excess amount of soft tissue deposition, you can have obstructive sleep apnea if there is more soft tissue in your palate or your hypopharynx region. Apart from that, they have a risk of diabetes and colon polyps. And these colon polyps are associated with an increased risk of adenocarcinoma of the colon. Okay, so this is about your acromegaly. So can you see in these photographs, this patient, can you see that he is much taller? He is having much larger feet and hands. There is some amount of prognathism. Can you compare here? This is your acromegaly, foot and hand. Okay, this is your acromegaly, foot and hand. So this is about the various presentations and clinical features of acromegaly. Alright, but there are a lot of conditions where the patient may appear that he is having acromegaly but he may not. So that is called as pseudoacromegaly. Okay, so where do you find pseudoacromegaly? You find it in your leonine facies, in leprosy. Right, so leonine feces which you see in leprosy is a cause of pseudoacromegaly. Then certain conditions like pachydermoperiosteitis, genetic conditions where you have large hands, feet. This is seen in your Sotos syndrome. Okay, so these are causes of pseudoacromegaly or acromegaloid features. So in this, your growth hormone IGF levels will be normal. Okay, so this is about your various clinical features for acromegaly. Now let us understand how do you diagnose acromegaly. So the screening test which is used in the diagnosis of acromegaly is your age-matched IGF levels, insulin-like growth factor levels. Okay, because growth hormone, as I mentioned before, it is pulsatile in nature, so there is no point of determining the growth hormone levels. So what we screen for is your age-matched IGF levels, and if it is higher than your cutoffs, then it can be considered for further evaluation for acromegaly. Okay, fine. The next confirmative test, if your age-matched IGF levels are high, then we use your oral glucose load of 75 gram. So when you give glucose, similar to how do you diagnose growth hormone deficiency, we give insulin. So how do you diagnose acromegaly? We give glucose. So if you give glucose, there should be a normal growth hormone suppression, right? The growth hormone should be suppressed. If you give insulin, growth hormone is stimulated. So if you give glucose, growth hormone should be suppressed. So growth hormone should be suppressed to less than 0.4 microgram per liter within 1 to 2 hours of your oral glucose load with 75 grams of oral glucose. Failure to do so, if there is no such suppression, then you diagnose this as acromegaly. Okay, so this is about your screening test and your oral glucose test for diagnosis of acromegaly. So this is about the diagnosis of acromegaly. Now once that you have confirmed that there is acromegaly, what are the other things that you want to do? The other things that you want to do is you have to find out the etiology. So the most common cause is a pituitary adenoma. So you will have to do a MRI brain to find out if there is a pituitary adenoma. If the MRI brain is negative, there is no evidence of pituitary adenoma, there is no evidence of any hypothalamic causes or pituitary causes, then you will have to search for ectopics. You will have to search for ectopic production. So you may, most often ectopic production is due to malignancy. So you may have to do a PET CT, look for evidence of any malignancy which is responsible for this. Okay, fine. Now let us move on to the treatment of acromegaly. So if you have diagnosed a pituitary adenoma, then the initial treatment will be a surgery. So here we are specifically talking about the pituitary adenoma causing acromegaly. So the initial treatment for the pituitary adenoma is always a surgery. Okay. So what is the type of surgery that we do? So this is, as the image suggests, is a transsphenoidal surgery. Okay. So can you see that the pituitary tumor is here? This is your pituitary tumor. Okay. So you basically approach a transnasal and a transsphenoidal approach where you go through the sphenoid sinus and you operate on the tumor and debulk it. Okay. So this is your transsphenoidal surgery for resection of adenoma, So the first line treatment for acromegaly will be a transsphenoidal surgery. Okay. Then there are certain medications which can be used for the management. So growth hormone, we know that it acts on certain receptors. Which are those receptors? They are your SST2 and SST5, which are your somatostatin receptors. Okay. So these have an inhibitory action on the growth hormone. So somatostatin receptor ligands are used in the management of acromegaly. These somatostatin receptor ligands, when are they used? They are used in frailty, right? In frail individuals who cannot undergo surgery, you give them medications. Then it can be used as adjuvant for perioperative shrinkage. If the tumor is very, very large, you cannot operate it easily. So you may have to give them somatostatin receptor ligands. And immediate relief of debilitating symptoms. So somatostatin receptor ligands usually have a very fast onset of action. So if there are very, very debilitating symptoms, you can give a trial of medical management. So what are the examples for somatostatin receptor ligands? This include your octreotide and your lanreotide. Okay. So we've learnt about 1, surgery, 2, about your somatostatin receptor ligands. 3. The other method is your radiotherapy. Okay, so radiotherapy can also be used to debulk the tumors, but radiotherapy nowadays is out of favor. Okay, it is out of favor mainly because it has certain disadvantages. The disadvantages is that the response is quite slow. And the chances of hypopituitarism after radiotherapy. Is much higher, right? So that is the reason why we usually prefer surgery or we prefer medical management with somatostatin receptor ligands. Okay. So let us talk about the SRL or the somatostatin receptor ligands a little bit more in detail. So what are the receptors that they act on? They act on the SST2, SST5 receptors. What are the examples? We have octreotide, lanreotide, right? So these basically are given as depot injections. They are given as depot injections. So what is the use of that? They have longer duration of action, right? So the duration of action can go up to 6 weeks. So they have a longer duration of action. And the response rate is that they cause shrinkage of the adenoma. They can cause shrinkage of the adenoma in up to 50 to 60% of the individuals. They can cause shrinkage of the adenoma in up to 50 to 60% of the individuals. Now, what is this other drug here? Pasireotide. Pasireotide is a SST5 ligand. This is an SST5 ligand and it is much more longer acting. And in patients where the octreotide or your lanreotide has failed. So in cases where the octreotide lanreotide has failed, you can use this pasireotide. Okay. What are the side effects of somatostatin receptor ligand therapy? So this is an injectable, so you can have injection site reactions. So what are the injection site reactions? You can have a flu-like reaction, you can have a rash, sometimes they can develop bradycardia as well. They also have GI side effects like diarrhea. Over the course of time, there is an increased risk of cholesterol gallstones as well. Cholelithiasis, cholesterol gallstones. Okay. So this is about your SRLs or your somatostatin receptor ligands. There is another group of medications which can be used in the management of acromegaly, that is your growth hormone receptor antagonist. And the drug that is called here, the drug is pegvisomant. Okay. So this is also given as a daily SC injection. Pegvisomant therapy, and the response is much higher. It can be up to 70% of the individuals can have a good response to therapy, but it's not used as first line. Okay. So now let us understand the approach to acromegaly. So you have a growth hormone secreting tumor. So 98% of the patients of acromegaly is due to a growth hormone secreting pituitary adenoma. So the first line management is always a surgery. First line management is always a surgery. If you cannot do a surgery due to contraindications, then you do a medical line of management. If there has been no improvement in symptoms with your surgery, then you give your somatostatin receptor ligands. If there is no improvement, then you move on to your pegvisomant therapy or you repeat a surgery. If there is no improvement with that as well, then you give combination like your SRL plus pegvisomant or your pasireotide therapy, and the last line management would be a radiotherapy. If there is no improvement at all to any of these combinations, you do a radiotherapy. Okay. So this is about your flow chart to acromegaly. Right. So with this, we come to the end of our session on growth hormone excess, which is your acromegaly. So what all did we learn in this session? To recap, we have learned about what is acromegaly. We have understood the etiologies, growth hormone and GHRH related. We have understood the various clinical features, what is pseudoacromegaly. Then we have learned how do you diagnose and what is the approach to treatment and management of acromegaly. Thank you.